So welcome everyone to the Stanford Care Community Health Talk series. Today is Thursday, April 2022, April 14, 2022, and I'm Dr. Malati Srinivasan, Associate Director of Stanford Care, the Center for Asian Health Research and Education. And I'm very pleased to introduce our good friend and colleague, Dr. Jochen Profit, who's going to talk to us today about health outcomes for Asian and Pacific Islander women and newborns. Dr. Profit is a professor of pediatrics and chief quality officer for the California Perinatal Quality Care Collaborative and director of the Perinatal Health Systems Research for the Department of Pediatrics. He is interested in the effect of a health system design on quality of care and outcomes for sick newborns. And this includes healthcare delivery design at the macro system level, as well as organizational content at the hospital and the neonatal intensive care unit level. He's been using this kind of information technology to support patients, families, care professionals, and policymakers to really be able to provide optimal care for sick infants. This is particularly important for Asian Americans, since the health outcomes for Asian American women and children in the perinatal setting is not really well known and well described. And he's going to give us an update today on where we are with that information and what we can do from a policy perspective and from a community perspective to move forward. Dr. Profit had done his medical training in Germany. He had done his pediatric residency at Tufts University and his neonatal fellowship and his master's in public health at Harvard. He joins us today, I think, from Stanford. I'm not sure if he's traveling or not right now. And we're very pleased to welcome him. And before we get started, I do want to thank our sponsors, the Stanford Health Library, the Lane Library, and the Vincent Wu Foundation. And special thanks to Stanford Video for their ongoing technology support. And with that, Dr. Profit, please be welcome. And we're so looking forward to your comments.
Thank you so much, Dr. Srinivasan. It's a real pleasure to be here tonight. I wish this was in a little lecture hall or something where I could see everybody and not just stare into my computer, but we're also used to this by now. So what I was hoping to do today is really take you a little bit on a whirlwind tour across maybe like 10 years of practice and research that we've been doing in California. And let you know a little bit about sort of health equity and general perinatal, so maternal as well as neonatal work that we've been doing. Now, I'm a neonatologist, so I'll be focusing a little more on the neonatal health outcomes, but I'll try to touch at least upon some of the maternal health issues as well. I first wanted to introduce the organization that I help lead to you. It's called the California Perinatal Quality Care Collaborative, and it's a real gem here in the Bay Area and California in general. So this collaborative, which is a perinatal collaborative, which includes a neonatal group as well as a maternal group, is really somewhat unique in the country and has been at the forefront of health improvements for mothers and newborns throughout the country, if not in the world. We have very unique data sets, and we're in a large state. So we have a benefit of actually getting data across a large number of babies, which allows us and mothers, which allows us to learn and improve care in ways that other states have not been able to. So there's about 500,000 births in California, and we, through birth certificates and other means, receive data on all of those births. About 17,000 babies a year are admitted to a newborn intensive care unit, and we receive pretty granular data from more than 140 newborn intensive care units, and I don't have this on this slide, but it's about 250 maternity hospitals in the state, and nearly all of them, as well as hospitals across the West Coast, all the way up to Washington State, provide data to our data sets. Babies are sometimes transferred from one hospital to another hospital, and a very unique thing that we also have in California is that we can track these babies, and we know about the quality of the transport of these babies from one hospital to another. And then also uniquely, we're actually connected to high-risk infant follow-up programs. It's really critical to track what happens to babies after they have to have a stay in newborn intensive care unit. So a lot of the babies that we take care of in the newborn intensive care unit are premature babies, but also a lot of babies, actually the vast majority of babies are larger babies, and many of them with congenital anomalies, or just babies that are generally sick at the time of birth and require intensive care. So all of these data sets are linked, which is really a unique advantage we have. And then as an organization, what we do, all of these hospitals are member institutions, and we provide them with essentially feedback reports and benchmarking reports so they can compare how they're doing in relation to their peers. And physicians and nurses are a bunch of competitive people. Otherwise, they probably never made it to medical school in the first place. And they don't like to be kind of, not on the top of the heap. And so just the motivation to see how you're doing compared to your peers is a big incentivizer to improve care. We also bring hospitals together in quality improvement collaboratives, such that hospitals learn from one another and how to, and there's really a lot of sharing of expertise going on, and potentially better ways to take care of mothers and newborns. We provide education throughout the state in various ways, through conferences, webinars, etc. And we also use the data and the work that we do, sort of applied work with all of our other hospitals to conduct research. So really quite an impressive endeavor overall. I'll show you a little bit more. This is kind of like one of the feedback reports that each hospital can kind of see something similar to this. This is just for the neonatal outcomes. Something similar exists for maternal outcomes. And without going into too much detail, you can kind of see, like, if you're doing well in an aspect of care that is green, that means you're kind of good. And if you're not doing so well in an aspect that's kind of red, that's maybe not so good. And we provide you with trend data, and we provide you with all kind of ways, almost these like little icons here to dive a lot more into the details of these data items to kind of understand what's going on, where you're doing well, and where you're having challenges. And this is really something that's quite unique to this to our state. Here's an example of collaboratives that we've run. So these are sort of multi-center. There's about 25 to 30 hospitals that typically participate in these collaboratives. And here was one to reduce the number of antibiotics used. Antibiotics are good if you're using them for an infection. If you're using them if there's no infection, if you're too generous when using them when you actually don't need them, they can cause harm. And so through this collaborative, we were actually able, for instance, there's just an example we were saving over almost 12,000 antibiotic days within the state. Actually, outside of these particular NICUs that did this collaborative, we then spread the learnings to the other hospitals, and over like 50,000 antibiotic days have been saved, like sort of annually, just based on those efforts. We had another collaborative where we focused on healthcare associated infections. Those are obviously a big deal, especially if you're like a small, vulnerable preterm infant in a newborn intensive care unit. When you get an infection, you can get very sick, you can die from those. And in the collaborative that we ran through NICUs, here 20 NICUs, almost 19 participating in this collaborative, we reduced healthcare infections by over 75%. So really huge improvements through this kind of collaborative improvement work. Here's an example of education. We've worked a lot in health equity, really not just since the pandemic, but before. But here's kind of like one of the educational sessions that we held, which was really focusing heavily on health equity. We have these every year. There's like a major kind of meeting that focuses on different topics, and so we kind of bring the newest information and learnings to a wider community. And these are multidisciplinary learnings. It's not just physicians, nurses, respiratory care providers, social workers, many folks that really are required to make a difference to our patients. And so here's been our impact over the years. This is data from the CDC, in which you can see that California actually was the only state in the nation that significantly decreased perinatal mortality a number of years ago. And Actually, California, and I don't have this slide here, but I just want to give a shout out to our maternal colleagues. California has been the shining light really for reducing maternal mortality in the country. And again, it's been the work of the CPQCC, the Maternal Quality Collaborative, that's been really the kind of beacon throughout the country on how to do this. And I'll show you a little bit of data about that. So here are some other impacts for our neonates. This is a paper we published just a couple of years ago. It's about 10 years worth of data. So in this 10 years, we've reduced mortality for very low birth weight infants by over 15%. And this is during a time where there was really no sort of new magic bullet being developed through basic science or things like that. There's some medicines that really seem to help a lot. Most of these were developed in the 70s and 80s, maybe really like applied in the 90s. But really over the last 20, 25 years, there hasn't really been a major kind of technological advance for these babies. So a lot of these improvements that I'm showing you are really just based on doing things better in a more coordinated way. About 10% of babies, like you might have heard, a lot of these small babies survive with disabilities. So an extra 10% of these babies, even though over time they get actually smaller, we're saving smaller and smaller, younger and younger babies, they're surviving with less eye disease, less bowel disease, less lung disease, less brain disease. So those are all good things. Almost 50% lower rates of a terrifying disease of prematurity, which is called necrotizing enterocolitis, which is a terrible condition that can lead to death or long-term disability. 20% lower rates of brain hemorrhages, almost 40% lower rates of surgery for eye disease, and almost 45% reduction in infection rates. So massive improvements, really. These are 2021 ratings. US News World Report really like 4 of the top 5 ranked neonatal hospitals were all from California. So I think that sort of demonstrates the impact that we have had. And so okay, how does this relate to health equity? Well, when we think of like quality of care, what we don't like is variation in care, and there's a lot of ways to get variation in care. One of the ways that we can find variation is we treat people differently, and so that could be, so health equity could be obviously an area where we might be treating patients differently. Now, when we started this work, maybe about 6-7 years ago, people really didn't believe that was a thing. Like, it's like we're treating everybody the same. They're all little babies. Everybody gets the same care. There's kind of like really health inequity doesn't really exist in a hospital. What does exist is that mothers experience pregnancies that are higher risk or lower risk. And if they have more risk during pregnancy, then they're more likely to have a preterm baby, and that baby might be in worse shape because the pregnancy was more problematic. But once babies are born, it was sort of perceived that really just sort of like, everybody was getting the same care. And so we were kind of interested in this. And before I tell you kind of more about health equity, I just wanted to, obviously highlight that a lot of things have happened, in the last couple of years, and really with the COVID pandemic, the kind of inequities in healthcare delivery have been really brought to the forefront, right? And so I mean, this has been most visible, of course, for Black and Latino patients who have been dying at much higher rates than white patients. But there's also been a real noticeable uptick of sort of like outright racism against Asian populations. And when we think about like, well, what might be happening in healthcare, where we don't really like to see things like health inequities, there's always sort of the question of whether, in the hospital, do we live in like a cocoon, where we kind of live, like where we can put everything that sort of exists outside of the healthcare system, we can shut that out, we can put it away, and we just kind of like treat everybody the same. But the thing is that we're all influenced by the biases that we face every day in our lives. We face them in the news that we watch, and the people we talk to, the pictures we see. And so you see this picture here, and each one of you might have sort of a different thought about what this picture implies, right? There's like there's a different example I just wanted to show you here, which is from Google, which kind of shows you how biases are really all around us, and we're exposed to them, and we may not be aware of them. So if you typed a couple of years ago, I think they've sort of tried to address this now, so you can check yourself if they're still true. But if you if you type 3 Black teenagers and 3 white teenagers into Google, you would find these very different looking pictures, right? There are the 3 Black teenagers, like these guys all look like they're, so it's like mug shots or criminal shots. And the 3 white teenagers are sort of these happy-go-lucky, playing sports, like happy teenagers. And so, even like I'm going to just assume that Google didn't sort of build this algorithm intentionally, but this is kind of like what the algorithm shows us and what it perpetuates to the people who use the platform. And so when we think of health equity and health disparities, essentially here's kind of sort of our framework for thinking about it. So there's a large part here on the left, which is what is called social determinants of health. And those are all the things like poverty, income, healthy access to healthy foods and education, equal rights, maybe police violence, the ability for kids to play in parks, and transportation availability. All of these things influence how healthy a pregnancy is. They influence the epigenetic, the expression of genes in patients, and that expression in moms of genes then actually also influences the health of pregnancy. So there's like we can trace these kind of stressors if these things are suboptimal into genomes. But whether it's through genomes or through other mechanisms, of course, the mom eventually gives birth at a hospital. And then once the baby is born, we would hope that the baby receives equal care and hopefully good enough care that we get these like cute little babies, and they're born and they're healthy and they look wonderful and they can go home. But then also these babies will end up going home and back into their environment. If that environment is still kind of adverse, you can imagine how long-term outcomes for babies might not be optimal. And so we were really kind of the first one to kind of try to focus here through the CPQCC and the CMQCC, what's happening here in the hospital. And so we looked at a literature. This is a study by Krista Sigurdsson in our lab that did sort of a systematic review of the literature, scoured like hundreds of articles, and essentially categorized articles that looked at disparities in the care of newborns into whether there were sort of structural differences in the hospitals where they were being taken care of. And these are things like nurse staffing ratios and whether or not patients are born in inappropriate hospitals that can take care of certain kids that have certain levels of needs. There are processes of care, whether we do certain things that we know work well, whether those are being done or not, and whether patients have different outcomes. And essentially, we found sort of evidence of disparities for all of these different areas in care, kind of highlighting that indeed there is actually differential cares being given, which was kind of like a shock to people who mostly thought like, well, look, we really give the same care to everybody. Well, if we just think about like, okay, like how might it be? What could be the mechanisms that we might give different care to different babies in the NICU? And so Elizabeth Howell actually was an obstetrician, used to work at Mount Sinai in New York, is now at Penn. She develops like a framework, and I think this still holds true, and it holds true for really any race ethnicity, whether it's Asian, Black, Hispanic. Essentially, like disparities can come about in 2 ways. First, we could segregate patients into hospitals that are just lower performing. And they might not be lower performing because there's like bad hospitals. It might be that they get lower reimbursements. So you could be safety net hospitals. They don't have a lot of funds. They may not be able to have a lot of nurses taking care of each patient, ancillary services that you need in a newborn intensive care unit, like lactation consultants or physical therapists and social workers, et cetera, et cetera. So by segregating vulnerable populations into those kind of facilities, you kind of ensure that you might get worse outcomes for those patients. Or you could be in a given hospital, like in my hospital, and it could be that, whether we know it or not, and a lot of these things really are not sort of deliberate care like decisions, but we might give more preference to some patients over others. And we could call this interpersonal racism versus the segregation is more like a structural racism kind of construct. And so here's an example for actually this is both for like a disparity within NICUs as well as disparities between NICUs. So here's data from California, where I'll walk you through this here a little bit. The measure that we're using here is called the baby monitor, which is a composite of NICU quality of care for small babies. These are very low birth weight babies, like 3 pounds at birth and less. So these babies are very vulnerable. They have a lot of like intensive care needs, stay in NICU for a long period of time, sometimes months. And there's sort of a number of different things that like a group of experts felt like all of these kind of individual measures represent kind of quality of care. And we put them together, and then we kind of like just show for each hospital what their sort of composite score is. And so the farther you are here on the right, the better is your score, and the further you're on the left, the worse is your score. And each one of these is one newborn intensive care, is one hospital, each one of these lines. And what we're doing here on the y-axis is actually just showing a difference by race. And so we're showing the black babies here in the red squares, and white babies are in the kind of blue diamonds. And so overall, what you can see is actually, well, it's not always a simple picture, isn't it? Because so there's some NICUs where essentially it's like almost the same, like whether you're like they're kind of, this NICU is like middle of the road quality, and black and white patients essentially have just the same outcomes. And there's others where white babies seem to do a lot better. White babies seem to do a lot better than black babies, even though this hospital is a really great hospital. It's one of the best in the whole state. But these babies here, these black babies, do just about the same as these babies here in one of the worst hospitals, as long as you're black. But the white babies here are much, much worse outcomes than the white babies in this hospital. Overall, when we look, there's a lot more kind of like blue dots that are faring better towards hospitals that perform better, and more kind of red dots in hospitals that overall perform worse. And when we do statistical measurements on those overall, like if you're black, you tend to be segregated, and you're more likely to be taken care of in hospitals that don't perform as well overall. Here's another very complicated study, but essentially this is national data. This is data from the whole country, a similar organization to us, but and they have like we're sort of one state within the whole US for this data set, and essentially, like, to make this a little bit easier, this is looking at whether or not patients get segregated into NICUs by race ethnicities. And if they were not, then these different lines here should essentially all be along the dashed line here. These different lines here represent Asians in light blue, and black patients in dark blue, and Hispanic patients in orange. And so that the fact that they all like deviate pretty far from the diagonal line here mean that there's significant segregation of these patients into hospital, where we mostly take care of them. Here's an example of within NICU differential care. And here, these investigators looked at kangaroo care, which is essentially a picture of this mom who's providing kangaroo care. It's a skin-to-skin care of a baby on the mom's chest. The baby is nice and happy and receiving warmth, and is feeling really happy here with mom. Now, if you don't speak the language, if you don't speak English, it turns out within the single NICU, you're going to be much less likely to have kangaroo care time, even though this is adjusted for how many times patients visited. So it's not that, maybe if you don't speak English, that like you don't have the ability to be there as much. So this is taken care of in the study. So, what's going on here? Likely, it's that there's less communication between the nursing staff here and the families because of a language barrier, and so there's less exchange of information around kangaroo care and less opportunity provided to do that. But we treat all the patients the same, right? So whenever I give this talk to professionals, to doctors, that's usually what I hear. It's like we treat everybody the same. Well, maybe we don't. So we actually asked folks one of the talks I gave, it's like, hey, why don't you write us a little story whether or not you've experienced disparate care in your NICU? And we asked families and physicians and nurses. There was over 1,200 people at a conference there. Over 300 of them wrote us a story which included a disparity. And it was not all about race, ethnicity. A lot of it was about language. It was about class, immigration status, etc. And essentially, when we analyzed these stories, there's sort of qualitative research to do this methodologies. You kind of analyze these stories for common themes, and you extract these common themes. And there were sort of 4 common themes. The fourth one is actually one that leads to maybe more privileged care. I don't want to say better care, because sometimes privileged care is actually not better care. But essentially, like there's some families that are really assertive and they receive priority treatment. There's sort of the VIP floor, so they get taken care of by the chief of staff or something like that. And it's not always a good thing, just by the way. But there's always this privilege that people have access to. But then there's kind of a number of ways in which people may receive suboptimal care. And one of them is through what we term neglectful care, which is where the NICU staff ignore, avoid, or neglect family needs like breastfeeding or kangaroo care support when it's considered just too difficult or unpleasant, or some obstacles are too great to overcome. And judgmental care is where staff evaluate the family's moral status based on race, class, immigration, etc., and circumstances or behaviors are judged more harshly. And then discrimination occurs through staff attitudes or resource allocation. And finally, systemic barriers, where staff was unable or unwilling to address barriers that families face, such as transportation or childcare, housing, translation needs, or religious or cultural needs. I just wanted to give you a couple of examples of these. So here's a story we got about neglectful care. So just a general observation: when I worked as a charge nurse, nurses tended to just ignore parents who did not speak their language. Often the use of a translator didn't occur daily for educational updates. These parents would have to sit by their baby's bedside and wonder how they were doing. These parents did not get the opportunity to interact and bond with the baby as a result. Here's another one. Is an example of judgmental care. A micro-premature infant born to new immigrant parents, lack of contact from parents and family, no phone calls or visits, resulting in distress in the NICU about parents' attachment and concerns regarding ability or appropriateness in parenting. When approaching the family, they expressed surprise and an expectation on them of inquiring of their baby, as they came from a culture where a patient enters a hospital and they get a call to pick up the family member when the patient is discharged. Lack of understanding of a North American culture of parents' involvement in care. This was a neonatal nurse practitioner regarding a family that he or she identified as Asian. Now, what we didn't find is that anybody really wrote about giving differential treatment to the babies directly. It was all really about how we treated families. So, when I first kind of learned about health equity research, I was taken during my master's in public health studies. I was honestly like a little taken aback, because I felt like I was hearing the same message over and over again. It's like, yeah, there's disparities, the poor are doing worse than the wealthy. And, it's always a kind of same message. And there was never anything about like trying to address it. And so initially, when we sort of embarked on this, I was kind of hesitant to really embark on this because like, I just don't want to just document disparities. I want to do something about them if we do. And so being part of this quality improvement organization, really, I feel like has sort of paved the way for me to really engage in this in a way that at least to me has been sort of transformational because I don't only have to talk about how there's problems, but we can kind of work on solutions. And so along the kind of things that we do as an organization, I'm just showing you a couple of examples, and there's more, but I'm showing you a couple of things in which we're trying to kind of really address health disparities. And so the first was like I told you about audit and feedback, which is like measurement, essentially quality measurement and feeding it back to providers and benchmarking. And so we've been working because family-centered care was it was like such a key pathway of disparate care. We're developing measures of family-centered care such that hospitals can improve what they do with regard to family-centered care. We've worked on a whole equity dashboard and got an NIH grant. So each of our NICUs, I'll show you the example, can actually look how their NICU is performing with regard to health equity. We formed a health equity committee. We get over 100 volunteer hours in a network from providers from all across the state. And so some of us have formed together a health equity committee in which we directly try to address like the main sources like interpersonal racism, structural racism, and we put out a NIH grant to hopefully get funding for that. And specifically, we would love to conduct actually a collaborative of hospitals that particularly serve the poor because they typically don't or they can't participate in our collaboratives because they just lack the funds, even though those funds are actually quite low, but they lack sometimes the funds to even for a couple of $1,000s to participate in those. And so we've submitted another grant to the National Institute of Health to hopefully help us address that. And whenever we do a quality improvement collaborative currently, we make sure we include equity aims so that we, because there is a possibility that as you try to improve quality to actually make equity worse, because sometimes the most benefits flow naturally to sort of the wealthiest patient populations first. We've focused strongly on patient education and various conferences. I showed you an example of that already. We've created sort of tip sheets for what hospitals could do right away. We've worked with parents. We always work closely with parents, and I'll invite you, if you're interested in any of the work that we're doing and want to participate, please contact me because we really appreciate working with folks who have direct lived experience of the things that we try to improve. And then finally, we conduct a fair bit of research. And so one of the kind of new endeavors that we've been dipping into is to look at our Asian American, Native Hawaiians, and Pacific Islander populations. And I'll talk a little bit about that as well. So there you go. So here's just an example of our family-centered care focus board. So this, this is a hot off the press here, April 2022. So now NICUs can look specifically how they're doing, and they can dive again deeper into all of these metrics and see, how are we faring with things like skin to skin, kangaroo care, or giving early breast milk, etc. So this is happening. Here's an example of our health equity dashboard, where NICUs can see kind of where they have challenges that they may want to address here in red, and I'll focus on one here for you because I figured you may have an interest in like Asian populations who have about almost 3 times the rate of severe eye disease as Black patients, and so these are things that previously were like totally invisible to our providers. They just that they wouldn't really know, and now they can kind of see where there's potential opportunities for them to improve. Here, Asian populations are actually doing really well with human milk nutrition, but I'll show you some data later. It's not universally true amongst different Asian subpopulations. And so, there's a lot of different ways that our providers can learn about what's going on in the NICU. Here's the example from our improvement committees, and our OB colleagues are focusing on respectful care. They have a number of efforts going on. We're working on family empowerment, education. We're working with these safety net NICUs that are really principally taking care of the poor. We're working on better ways to transition babies back into home and then to a high-risk infant follow-up program. We're also looking at ways to better serve populations that face challenges when they go back into their communities. Particularly during COVID, as you can imagine, there was a lot of difficulty in bringing and following patients up over time. So a lot of it had to be done through telehealth, etc. Telehealth is not available to everybody. Here's a tip sheet we developed with parents on how to provide better family-centered care. Here's a whole framework for institutional change we provided, where there's a lot of detail in this that providers can access and kind of follow up on. These are just initial ideas, but it's just ways for hospitals to get started. Here's some of the research we've done. Here's an example from the Maternal collaborative. This is Elliot Main, who's the leader in that. So severe maternal morbidity is a kind of a composite outcome of bad things that happen to moms when they go into labor. And the main thing for maternal morbidity is maternal hemorrhage, so excessive bleeding at the time of birth. And some moms die from excessive hemorrhage. And before the collaborative did sort of a statewide, or the maternal side did a statewide improvement collaborative. You can see the sort of average rate here was about 22%. And after the collaborative, it was decreased to about 18.6. And these red lines here are sort of they're called control limits, essentially, like looking at the random variation around all these individual points. So this already is highly successful. Mainly, what they did here really is they provided each hospital with what's called a sort of standard approach to treating and monitoring blood loss and treating blood loss, diagnosing it early, responding quickly. And there's like a physical kind of hemorrhage cart now, essentially in every labor and delivery floor, where rather than having to run to the blood bank to get blood, there's something right there that can be accessed if a mom is heavily bleeding to help and save her. And this sort of very technical approach, that had nothing to do actually with any sort of health equity training or bias training or any of those things, essentially eliminated the existing disparities in severe maternal morbidity in between Black and non-Black, like here, white patients. And so here in this chart, you can see before at baseline, before the intervention, these were the rates by race ethnicity. So white and Black and Asian. And so as Black was 28.6 and then whites was 19.8. And after the improvement collaborative, it decreased somewhat for white patients, but it increased substantially for Black patients. It's still a little bit higher, you could argue, but this is no longer statistically significant. So it's, while it's a little bit higher, it's almost the same at this stage. And so, interestingly enough, like a very kind of technical approach really led to an eradication of a disparity. Now, that might not work for everything, but it kind of falls into this sort of quality improvement, care standardization kind of paradigm that we as an organization excel in. So what about AANHPI populations? Well, and these slides I stole. They're courtesy of Dr. Palaniappan, who's the director of the Stanford Center for Asian Health Research and Education. So thank you to her. But I think these are terrific slides. So Asians represent 60% of the population of the globe, right, over a huge span of the earth. 6% of the US, but it's the fastest rising population, actually, immigrant population in the US. In the Bay Area, it's about 30%. So maybe sort of one of the large, like California and then the West Coast are the largest population of AANHPIs, and therefore maybe like the perfect place to kind of study them. But what it means when you come from a large portion of the globe is that these populations are actually hugely heterogeneous. But in almost all studies, they're just kind of reported as like one group, right? Asians. But what does it mean? It's like many cultures, over 30 countries, different lifestyle, different pregnancy, birth, and care behaviors, and some of which, depending on when people immigrated, may have been modified through acculturation because of life in the United States. And so this like really there's a highly heterogeneous group. It varies profoundly also in characteristics such as whether people speak English or their socioeconomic status, whether they have health insurance coverage, their beliefs about health and about the use of health services, their diets, their body mass index, and their lifestyles. And so, really, like, we shouldn't treat this group as like one group. and so, even worse, this like large group and rising group really only receives about 0.2% of funding from the National Institute of Health. Like, research on these populations only receives just a tiny fraction of NIH funding. And so we really wanted to like understand this population better, because this is the population we serve here in California, and we don't know enough about them. In principle, when we do comparisons with aggregated like Asians as one group, they tend to do pretty well, relatively similar to white populations. And so, is there really a problem? Well, I think the population is so heterogeneous, unless we look, we're not going to know. And so we proposed a study to the National Institute of Health to really study mothers and their newborns, and to really try to disaggregate all of these different populations to understand what types of populations face what barriers, and how we can work in partnership with these populations to understand their practices, their preferences, and then ultimately to find solutions like we try to do for other areas of health equity, so that we can optimize care for each one of the populations, AANHPI populations in California. So I hope that makes sense. This study brings together like a collaborative group, not just from Stanford, but also from UCSF and CPQCC, CPQCC, both located at Stanford. We kicked off our research just a couple of months ago in May with a conference. It was also funded by CARE, so thank you very much again. It was really a fascinating introduction into this landscape of research, because even though it's this first day where we just kind of presented sort of very basic data, we learned a lot already from different panels of patients and representatives from across the state and from many different groups. And so really just sort of created the first platform for us to understand what the needs are, what the pain points are, and maybe how we can work together in partnership with these groups to better understand the barriers and then eventually solve them. So I'm just going to give you a little bit of like an introduction into the moms and newborns that are AANHPI in California. This is very early work. This talk is maybe coming like 3 or 4 years too early, so we'll still need to do a lot more work. But I'll show you some preliminary data, and you can kind of get a sense of the kind of things that we'd be interested in. So here are deliveries in California. You can see there's about 133,000 total, 16% of the total in California, and you can kind of see the largest groups here. right? And I can show you this as a pie chart as well. So about 27% Chinese, Asian Indian 17, Filipino 15, et cetera, right? That's into smaller groups. And then there's also some interesting groups that are sort of Asian multiple. This is typically all based on the mom and the birth certificate and whatever the mom says that her heritage is. Like oftentimes on birth certificates, the paternal heritage is missing. And so we typically, when we do these studies, we focus first on whatever the mom provides. We can look at like where moms are born, and here the native Hawaiians, obviously almost all of them are born in the US, right? Because Hawaii is part of the US, quite obviously. You all know it, but here's another group, Asian Indians. Only about 11% of these patients are actually born in the US, and most of them immigrants. And you can kind of see the distribution here and understand that maybe many of them might not speak English very well, and might face quite a few barriers in accessing the healthcare system or interacting with the healthcare system. Here's maternal education level. Maternal education level is a very strong predictor of health and health outcomes, people's ability to navigate the healthcare system. And so this is a bachelor degree or higher, and you can see very highly educated groups over here, and then groups that have lower levels of education, and thus may face more health risks. So really variable, right? It's important. Essentially, all of these slides are showing that, like, just calling all of these groups just Asian as one thing just really doesn't make sense at all. Here's preterm birth. Now, Black women have much higher rates of preterm birth, which is the primary reason why infant mortality for Black babies is much higher. You can see here that the Filipino moms actually have even higher preterm birth rates, born in less than 37 weeks, than Black moms in California. And there's other groups who are really quite challenged. Cambodians and Laotians also very high preterm birth rates. You don't understand why this is. Again, this is just sort of preliminary data. Other groups, more like along the lines of European countries. Like even white moms in the US have much higher rates of preterm birth than compared to Europe, Australia, other Western countries. Here are very low birth weight infants, and as you can imagine, similarly to the distribution is going to be sort of relatively similar when we think to the moms. But here actually we got Filipinos higher. Like, remember, they also had higher rates of preterm. We see this again for not just less than 37 weeks, but we always see it for less than 1,500 grams. These are really much smaller babies than 37. These are more like 32 weeks and below babies usually. And then Asian Indians also more than the Chinese, which you might have thought from the prior data that I showed you would find more frequently. So some of the things we don't understand quite why this is. Here, how many babies are small? They're born small and early, but how many of those are even born really small just for their gestational age? So they're less than the 10th percentile for where they were supposed to be, even though they're already born small. And you can say, and we see this in a number of studies here, that there's a really high proportion of Asian Indians tend to have babies that are kind of smaller than the 10th percentile. And again, not quite sure. Similarly, here, Native Hawaiians and Filipino, again, relatively high rates, also Japanese. This is an outcome of newborn care, which is called chronic lung disease. Essentially, these are babies that need a ventilator or oxygen for a long period of time. And here we have Korean babies with quite a high rate, and it's really unclear why that is. Native Hawaiians are quite a good outcome here. Asian Indians, quite a good outcome. So you can see there's like really quite a bit of variability. breast milk at discharge, this is something we've really learned to affect this outcome and improve it over time. You can see great rates here of feeding at discharge for Japanese and Korean. But other Pacific Islanders, so these are the non-Hawaiian Pacific Islanders, really quite low rates and very challenged. And really, this could be an area where we could address. In hospital survival looks pretty good for everybody here, like between 90 and 95% for these babies that are born at least about like 8 weeks too early. So that's really good. Now I could have shown you this in mortality, and then I would have shown you maybe 10% mortality and 5% mortality, and I could have told you that other Pacific Islanders have twice the mortality of the Koreans and the Filipino babies. So I could have made it look worse and maybe more sensationalistic. But the fact that 90 to 95% of the babies survive is, I think, something to probably celebrate a little bit. Okay, so in summary, the NICU is not a social cocoon. Racism in the NICU does exist, and we need to just face it and address it. Most efforts have been focused on Black and Hispanic populations, but really the AANHPI group is very, very heterogeneous, and it deserves our attention because there's areas where we can improve quite a bit. And I just want to finish with this quote from Martin Luther King Jr., which is that of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And with this, I just want to thank you, show you faces of all the wonderful people that work with us at CPQCC, make all of this work happen, and invite you to join the discussion and conversation.
Dr. Profit, I can't thank you enough. It's such a wonderful talk. And I really appreciate how you took us through the entire thought processes of where the field of neonatal ICU care, newborn care moved us into structural racism and interpersonal racism, presented the data for the health equity dashboards, which is such an amazing contribution, and really showed us how data can bend the curve in terms of maternal fetal complications, and what a remarkable set of achievements. We're so grateful to you that you've now turned your attention to Asian disaggregated populations, and hopefully this grant through the NIH, this multi-center study, gets funded. I did want to ask you a few questions in regards to the influence of nativity and the influence of culturally appropriate care. I think that this is a major problem that a lot of the patients, especially who are from refugee populations or who are from some of the underserved Southeast Asian communities are facing. Even before this grant is funded, how would you recommend physicians and patients and families and communities support these communities who clearly are doing much worse?
Do you mean on an individual basis, or from the healthcare provider, or from the?
I would say, so the first would be from the healthcare system perspective, which I think involves both the delivery of care and the education of the providers.
Yeah, I mean, first of all, I think we need to make sure that the providers, that the patients understand us, and so I think, and maybe that's not always done, that we actually. First of all, ask whether people understand what we say, and not just whether they understand what we say, but whether they really comprehend what we say. Because and we also need to be a little humble and ask whether what we may recommend is appropriate to their cultural background. So there's one example comes to mind that one of our patient representatives told us about at the conference. She said, well, after she had a baby, one of the nurses came in and brought this huge cup of ice water, and her thought was I don't want the ice water because in my culture, I'm not supposed to drink something cold right now. It's kind of so it felt a little offensive. It's like a minor thing, but there's a sort of these level of communications that are just not quite there, and people don't really ask, and because they don't ask, they don't know. And when you're a patient, it's difficult because you don't always want to sort of, you don't want to like kind of piss off your care team by being sort of, oh, I'm going to be the difficult patient that's going to like, say X, Y, and Z. But I think you need to, you should, if you have trouble speaking the language, you should always ask, and you always have the right to ask for an interpreter. And you should absolutely do that. I always recommend to our patients to write everything down. Any question they have, any day we come by in rounds, I want to kind of see the piece of paper with the questions on it, because they'll forget as soon as we walk and we do rounds and they hear 150 different things about their baby. And then we always try to teach them and have them teach us back, so that we make sure that whatever we said, they understood. We actually try to make patients part of our rounds, and we ask, we go to the nurse, we ask what the nurse thinks about, there's sort of a process, the respiratory therapist, and we'll ask the family if is there anything that you would like us to do different, or is there anything that you would like us to stop doing, so that they kind of become used to, after doing this every morning when they can be there, that they're sort of part of the team and feel like they're part of the team and that their input is valued. But it's a journey that doesn't come, it doesn't happen from one day to the next. So I think patients need to, they need to know their rights, and they should feel free to express what they need and what works and what doesn't work for them. Because I think ultimately as physicians, we want things for our patients that work for them. Because if we just tell them to do things that they're not going to end up doing, it doesn't really help anybody. So yeah, I'll leave it at that. A long-winded answer.
Well, Dr. Profit, I can't thank you enough. This is such an amazing talk. It's very eye-opening, I think, for most of us in the audience who are not familiar with neonatal care and some of these very disturbing figures. Your work is groundbreaking. And again, as a community, I think we're very grateful to you. So on behalf of Stanford Care, I want to thank you again for coming and presenting, and thank all of our participants today. There's a whole series of questions into chat, and we'll probably send them to you and post them perhaps a little bit later with your permission. I'd also like to thank again the Stanford Library for funding this series, along with the Vincent Wu Foundation and Stanford Video for their wonderful technical support. I would like to also let our community know that the next Stanford Community Healthcare Talk will be on September 20th on how Nourish is giving Asians the tools to eat well and live well, with Dr. Minal Mohirer. And this is actually a really wonderful project that is on Facebook, where there's culturally appropriate and curated diabetic foods that are being made that highlight how you can translate the diabetic recommendations for better food practices into the traditionally very carb-heavy Asian diets. So Dr. Profit, again, thank you very much. And our audience and our community, thank you for coming and being such active participants. We'll make sure these questions get answered and post them as part of the video.
Thank you. It was my pleasure.